This video covers final part of lecture series on respiratory muscles. In this video, we will be covering physiological conditions and pathological conditions affecting respiratory muscles. In first section, let's see physiological condition affecting respiratory muscles. Respiratory muscles are not limited to ventilation alone. They also participate in functions like speech, laughing, swallowing, coughing, and vomiting. The interaction between these muscles changes depending on task and ventilatory demand. Respiratory muscle interaction. During quiet breathing, muscle activity is minimal and well coordinated. But during non-ventilatory activities, recruitment pattern changes. This leads to variation in chest wall movement depending on function being performed. Speech mechanics. Speech occurs during controlled expiration, usually below end expiratory lung volume. There is sequential recruitment of expiratory muscles. Initially, internal intercostals and triangularis sterni, followed by abdominal muscles like external oblique and rectus abdominis, and finally latissimus dorsi. Functional significance include abdominal muscle contraction during speech help in maintaining stable airflow and also support diaphragm function. It prevents loss of pressure and improve efficacy of breathing during phonation. Laughing is an emotional response that triggers coordination between respiratory and laryngeal systems. It usually occurs at low lung volumes near functional residual capacity and progress towards residual volume. Laughing is characterized by repeated expiratory efforts with sudden pressure changes. Expiratory muscles are strongly activated and gastric and esophageal pressures increase. Diaphragm plays a protective role by limiting excessive pressure transmission into thoracic cavity. During swallowing, respiration is temporarily interrupted. The diaphragm activity is modified to preserve lung volume, and abdominal muscles remain active before and after swallowing. This coordination is important to prevent aspiration. Vomiting. Vomiting involves coordinated action of inspiratory and expiratory muscles. The diaphragm and inspiratory muscles contract along with abdominal muscles, while internal intercostal muscles contribute during expulsion. Diaphragm around esophagus relaxes to facilitate movement of gastric contents. Cough, sneeze, gag. These are complex reflexes involving inspiratory phase, compressive phase, and expulsive phase. Maximum diaphragm force is generated, but effective cough mainly depend on expiratory muscle activation. Recruitment of muscles during cough. At low flow rates, expiratory muscles are sufficient. As cough intensity increases, accessory muscles are recruited. This sequential activation is important in generating high expiratory flow. Muscle testing. Respiratory muscle strength can be assessed using maneuvers like Muller's maneuver and sniff test. These activate different muscle groups and help in evaluating diaphragm functions. Postural role. Respiratory muscles also play a role in posture. Diaphragm activates even before the limb movement, contributing to spinal stability. This highlights its dual role in respiration and postural control. Now we move on to pathological conditions where this coordinated interaction is disturbed. Important examples of pathological conditions include hyperinflation, muscle weakness, mechanical ventilation, and spinal cord injury. Hyperinflation. Hyperinflation is commonly seen in COPD. It causes flattening and shortening of diaphragm. This reduces its ability to generate pressure effectively. Effect of hyperinflation. As diaphragm efficiency decreases, ribcage and accessory muscles take over. This leads to more ribcage predominant breathing pattern, which is less efficient. Length tension effect and zone of opposition. With hyperinflation, diaphragm shortens by around 30 to 40%. This places it at a mechanical disadvantage, significantly reducing force generation. Regarding zone of opposition is reduced in hyperinflation. This affects ability of diaphragm to expand ribcage, leading to ineffective ventilation. Exercise limitation. During exercise, dynamic hyperinflation leads to rapid shallow breathing. Inspiratory reserve is reduced, resulting in early fatigue and breathlessness. Next pathological condition, muscle weakness. Muscle weakness of respiratory muscle can result from hypoxia, hypercapnia, malnutrition, steroid use, and inactivity. These factors are common in critically ill patients. Prolonged mechanical ventilation leads to diaphragm inactivity, causing rapid muscle dysfunction. This is known as ventilator-induced diaphragm dysfunction. Spinal cord injury. In spinal cord injury, intercostal and abdominal muscles are lost, while diaphragm function may be preserved. However, cough becomes ineffective, leading to secretion retention. Quadriplegia. Patients with quadriplegia rely on accessory neck muscles for breathing. They have reduced endurance and are prone to respiratory muscle fatigue. Management. Management includes reducing hyperinflation through interventions like lung volume reduction surgery or lung transplantation, along with respiratory muscle training and nutritional optimization. In summary, respiratory muscle function depends on coordinated activity of multiple muscle groups. This interaction is affected in both physiological and pathological states, and understanding this is essential for effective clinical management.